Our next panel coming up is healthcare access or healthcare equity, depending on how you want to approach it. But recent studies have shown that despite the improvements in the overall health of the country, racial and ethnic minorities experience a much lower quality of healthcare. No surprise there. They are less likely to receive routine medical care and face higher rates of morbidity and mortality than non-minorities. It's also true that depending on the community in which they live, patients may experience great differentials in the quality of care provided. We believe we can use innovation to improve delivery and access to healthcare so that it does not discriminate based on race, geographic, or socioeconomic issues. Now, this is a very, very lofty goal, but first we have to appreciate the fact that it is, in fact, a problem. I'm joined today as our lead speaker by Dr. Juliette Nevins. Juliette is a fantastic contributor. She's actually the Clinical Solutions Director at Aetna, part of CVS Health, but she's also a practicing OBGYN and also the founder CEO of Below the Belly Button, providing consumer-targeted health education via digital and in-person platforms. I imagine with the name Below the Belly Button, this is specifically targeting maternal health and labor issues?
Correct. Yes, it's basically Well Woman's website, if you will.
Got it. And can you tell me a little bit, Julia, why did you focus on this aspect, other than the fact that you're OBGYN? What are the main concerns that you have here?
Well, a lot of the disparities affect women. We've heard in the last year about the increased morbidity and mortality in terms of maternal care. And if you look at other diagnoses, there too, you'll find that a lot of the disparities affect women across the board. And certainly if you get granular, you'll find that those disparities target women of color. My interest has always been aligned with my clinical career as an OBGYN, in that my interest is in terms of population health, is getting to the policies and the programs that are important for this cohort.
Now, I suppose the first most important thing is we acknowledge that it is a problem. So thank goodness we're starting to actually bring this up as a major issue. Now, I am aware that the Black Women's Congressional Caucus came up with something called the Black Momnibus. Could you tell us a little bit about that and what the purpose of that was?
So it's a compilation, if you will, of different programs and policies that the group who came up with the Momnibus hoped to enact. Technology is one part of it. Ways to address social determinants of health is another part of it. So it's a multi-pronged approach in terms of putting laws and mandates in place that will trickle down and target this problem in its totality.
Got it. So outside of maternal health, which obviously is your focus specifically, I imagine you are dealing with a lot of other aspects of this in terms of drug delivery, in terms of healthcare delivery, in terms of telemedicine access. If you had something that you would like to educate our audience on that they may not know about in terms of negative impact of healthcare delivery, not negative impact of delivery, lack of delivery, let's say, what would that be? Like, give us a nugget of wisdom that we can start with.
Well, I'm glad I joined early because I was able to hear the conversation from the prior panel. And all of this does tie into the mental health that affects this group. And it lends to a circuitous sort of pathway, right? When people don't feel involved, when they don't feel heard or seen, that in of self is often unquantifiable. It's untangible, but that then too leads to worse outcomes for certain cohorts. So it's a nuanced look at this. There are certainly a lot of pieces that we can look at and focus on, but I think that's one avenue that we should definitely pay attention to. And I wanted to share that with the audience today.
I think that's so excellently put. So many of the issues that we brought up, when we thought of these 5 channels originally 4 months ago, before we started doing the research into them, they felt like 5 separate channels. Now we realize it's one giant channel that's all just with different focuses. Like, in many ways, we need to go back and start thinking about how do we create better interaction between all of these different pathways themselves. So to that point, you mentioned something about not being seen, not being heard. In my mind, that also leads into this aspect of lack of trust of the system itself, that they don't trust that the system's hearing them. And it's kind of been proven out in many ways. Is that right?
Well, that is absolutely correct. You know, I look at the issue around access in sort of a hierarchical function, right? There are the larger structural issues that then trickle down and lead to poor outcomes. Your zip code, where you live, and where you live determines variables that directly impact your health. You know, food deserts, for example, safe places to get exercise, health literacy. So we can start there. Then, based on that, if you have a complex diagnosis that requires an entity that's optimally resourced to take care of that, is anyone even referring you? Is anyone saying, you know what, you can't care, you know, we can't optimally care for this problem here, go to entity X? Do you have transportation to get there? Do you really have the health literacy to understand the concept of a higher level of care? And that's where I come in, because I am very much about health literacy and making sure that patients and people in the community understand what diabetes is. It's not just sugar. What does it do? Do you know that it's the leading cause of blindness for adults in America? So these are pearls, really important nuggets of information that if the patients and if the population who suffer for them most really understood, I think that would lend to an impetus for them to act and to be more involved.
So in many ways, we have another feedback loop here, right? Is that many of these underserved communities don't trust the system to take care of them, don't trust them to see or hear them, and therefore they're not seeking education or support. And so we need to circumvent that. We need to short circuit it.
Or they don't believe the information that's being given.
There you go. So we need to start somewhere. Now, the good news is we can start with education. Would you propose this then as your first and foremost aspect of dealing with the healthcare access, or is there other issues that you would like us to be aware about also?
Well, in terms of my niche, that's my focus. And on your last panel, a member of one of your panelists said it, you know, really, she used the term group care, if you will. And I think that's certainly another important component, educating the population so that they can really be involved in shared decision making, so that they can be stakeholders in what's happening around them. And with information, you can better vet what's for you, what's not for you. And if you understand at baseline, then you can have a conversation with your provider where you're going in with a different level of trust.
Excellent. Thank you so much. If there was one other thing that we would address, now, obviously, when we talk about equity and access, many parts of that are financially based. But we've addressed now at least one item, really two, both education and I would say community support or community networking, your local support group plus the community support group. Is there another way that doesn't involve like direct taxation kind of thing? Is there something where innovation in your mind would be the most effective means of support, whether it be telemedicine, whether it be behavioral modification in terms of health monitoring, like with our smartwatches, or anything else like that? Like, what's your wish item if you saw the previous panel?
Well, I will tell you, you know, technology is very important. And I think as we emerge out of this pandemic, what we have seen is that patients are willing to access healthcare virtually, if you will. And we can tap into that. We can use that to shorten wait times for either mental health providers. If you are a diabetic and you have been taught, or you have an app on your phone such that you are monitoring your sugars, virtually you can convey that information to your provider and get care. That provider can, for example, adjust your insulin at an earlier point in your disease, as opposed to waiting until you come in 6 months later. So that's a concrete example of how technology at the point of the individual can be helpful. In terms of our infrastructure, I will tell you, my one pet peeve when I was a resident is the electronic medical records. In that everybody has one, but nothing is connected, right?
Yeah.
There's no way you can get objective data about what's going on with the patients if they have been seen or if they received care in a different facility. So
Well, I think we're gonna have to be bringing people on to like as guests of other parts of our panel. In fact, bridging the digital divide is a specific topic around medical records and integrating these things. So we're definitely going to have you there.
Wonderful.
Well, you can chime in from the audience, and maybe we'll bring you on if we have the time. But there was one thing I wanted to bring up before I hand it off to Katie, Dr. Richardson, and that's that does a virtual healthcare system suffer or solve issues of trust? Like, meaning having it virtual, there's got to be a trust component. Is having it at arm's distance in terms of relying on this network, is that like better or worse in terms of building trust with the patient?
It cannot replace the face-to-face interaction. We should think of it as an adjunct, not a replacement. So, and I like to use concrete examples so that we're not talking about intangible things or intangible situations. Once you have established a relationship with your physician, you can then employ virtual access or virtual medicine as a means of continuing care or continuing that relationship, or as a way of reducing the interval between visits. So that's one thing. It's an adjunct. It's not a replacement. And the other thing I always stress when I talk about this, it works alongside the in-person visitations, in that the providers have an opportunity to triage, right? Decide what patient is amenable to the virtual access, what level of disease burden, for example, is amenable to the virtual access. It's a tool. If we start thinking about it as a replacement, I think we're going to go down the wrong line. But if you have an established patient, my doctor told me to come back in 6 months. Okay, I'm not doing that. So let's set up a virtual visit so I can talk to you and tell you about what's going on with me in the meantime.
I couldn't imagine a better transition for me to bring in my pitch club partner here, Dr. Katie Richardson. She and I have had many conversations on topics of healthcare equity, and one of the things that comes up is the concept of being able to triage to provide better access. So I'm going to hand off and start there, and then maybe ask you to talk a little bit about some of the other observations that Dr. Nevins has made thus far.
Absolutely. Thanks, Mike. And thanks, Juliette. Some great points, I think, to start this conversation out. But I 100% agree, right? Healthcare relationships between provider and patient, no matter at what level, are built on trust. So being able to develop that trust with your patient is important. A lot of times that is a face-to-face visit to begin with. But we also know or have seen in cases, again, to tie it back to actually our previous conversation, our previous topic, the crisis text line that is out there, again, is a nationwide opportunity for folks, again, who are in mental health crisis. And what they have found is there are many patients that are much more willing to share because of the anonymity that comes along with that text conversation that's happening. So again, I think it's got to be a balance, and Juliette said that. And Mike, to your point, this idea that we do need to help patients understand. So where are they going to be best served? How do we help them triage from a perspective of, do they need to be in the emergency room? Does it need to be a face-to-face visit in the office, or could it be a virtual visit? Because I think there are, many different ways to access care, and this idea that we need kind of navigation support for many patients, the way that I would talk about it. No matter whether we are talking about healthcare disparities or not, the healthcare system is hard to navigate. And so solutions in that space, I think, would be great. I want to set a little bit the stage for the remainder of this discussion just by putting out there what I think is a great definition of healthcare equity. So healthcare equity or health equity generally refers to individuals achieving their highest level of health through the elimination of disparities in health and health care. So again, this idea that health and healthcare are not necessarily the same thing, right? We are talking about two different things. And we know that there are factors both within the healthcare system and far beyond that. And Juliette, you tapped into many of those, I think. It is your zip code. It is your education level. It also is, are you employed? Do you have a roof over your head? Many of those things, in addition to another point you made, which I thought was awesome, this idea of social support systems and that social integration. We talk about food as medicine. So the other thing would be, food security or food insecurity. And then one of the other, I think baseline disparity really is access to the healthcare system. So this idea, again, that is one of those larger areas that we're talking about. And although we made great gains, I was just going to say quickly, in coverage for a lot of patients out there, we have seen in the past 4 years kind of a backslide in the amount of coverage and the folks that are covered out there. So those are all aspects that I hope we get to talk about with our panel. Go ahead, Mike.
Yeah, that's all right. I just wanted to bring in Kaapama Yapala here. That's all right. I messed up your last name. I practiced your first name.
We'll call him KP.
KP from here on out. Thank you. Take the pressure off.
Well done. Good.
Much appreciated. Kaapama I got. It was the last name that I hadn't practiced, so I apologize for that. But KP. So KP, he's currently the founder and CEO of In-On Health, and they're specifically looking at technological solutions to increase access to both education and other aspects. KP, maybe just tell us a brief bit about what the issues are, not that In-On Health is trying to solve, but why they need to be solved, and maybe the work that you're doing with the Commission for IT in the state of Colorado and the work you're doing with the state governance in terms of providing more access there. Yeah, there we have access and engagement issues. There you go. It's all about access, right?
Great. Indeed. Can you hear me well?
We can now, yes. Thank
Very
you.
good. Thanks so much for having me. And Dr. Nevins, you really kind of teed up some key issues, as well as Dr. Richardson. So I go by KP. I think, as we all know, the conversation about health equity is one that's oriented or anchored around values in our society, right? So really what we're getting at the heart of it is that there are avoidable disparities in our country based on systemic issues, race, gender, sexual orientation, all the things. And really what health equity is about, in my view, is reducing those disparities and setting the intention as a society that that's what we believe is the right thing to do. And if we all align that that's the right thing to do, then we're going to take the action to do that, right? So for me, just like as a principle, like that's the why, right? I mean, in terms of what we do, and we are, my parents are both from Ghana, so my family are immigrants to the U.S. I'm a first-generation American. And the issues of healthcare access for BIPOC populations, and also globally, like my career has also done this work in African countries, is that, there are ways that we can reduce disparities. There are ways that if we're intentional, particularly around using digital innovation, that we can bridge the gap. But if we're not intentional, as has been brought up, digital innovations aren't equally accessible, right? So actually digital innovation can deepen disparities if we're not careful. But I think that, here in Colorado, I'm based in Denver. I'm the incoming chair of the Colorado eHealth Commission, which governs all health IT for our state. And the specific mandate, and part of why I've been brought into this role, is to really focus on how we think about digital inclusion and operationalizing digital health equity. So not just setting the principles, but ensuring that what we do and how we use technology bridges the gap. So Really passionate about the topic. Really curious to hear from my colleagues here on the panel today, and add whatever insights I can.
Well, let me introduce Daryl Chapman now. Sorry, Katie. I just want to bring in Daryl.
Go for it.
His intro, and then you guys can take it from there. So Daryl, actually, I met him just a couple of days ago, or a week ago now, I suppose, via some connections we have here from Dr. Jeff Cohen, who will be the lead speaker on one of our later panels. Daryl's got a really remarkable background, including his current work right now, working to improve pharmaceutical distribution in African countries via a IT network and decrease the amount of counterfeiting going on there. But also Daryl has some unique insights on what he's learned from developing that product and how it can be brought back to the US in terms of improving access and creating a more equitable playing field. Daryl, could you talk a little bit about that?
Absolutely. So my name is Daryl Chapman, and going on that, and KP hit it perfectly on the nail, is being intentional. And both of my experience over doing work in Ghana and in Nigeria, you do have to be very intentional with what initiative you are putting in place and understanding the ecosystem and the environment that you're working on, because a lot of the issues that they're dealing with and a lot of barriers that they're dealing with on a day-to-day basis is seen as almost a luxury when you come back over to the United States, but they are still prevalent throughout the United States in what we call these healthcare deserts. These healthcare deserts, which are in the low socioeconomic communities within America. So it's one of those things where you do go overseas, you see these issues, and that may be a norm for them. And as us as Americans who are tailored and trained to think as though that's something that just happens in a third world country, but that's actually false. It's something that happens, in our neighborhoods and in our backyards. I know me specifically, I'm from Flint, Michigan, and I hit it day to day, every single day. I have the disparity of not having access to adequate care and dealing with issues as far as health access.
Great. And Mike, do you also want to introduce Mark J. we have up here too?
Certainly is. Hi, Mark. How are you? Thanks for joining us today. Mark is the Senior Fellow at the Center for Healthcare Affordability out of the Sagamore Institute. And these guys are really doing an amazing work in terms of improving, well, let's put it this way. They're trying to curate strategic solutions to fix America's broken healthcare system, which basically makes him a poster child for exactly the Impact Conference and what we're trying to do here together. So, Mark, based on what you've heard so far from these extremely wise individuals, I would say, what do you think so far in terms of what work you're doing specifically to try to address some of their issues?
Yes. Thank you for having me. And, Dr. Nevins made an interesting point, and several others have too, is there's a lack of trust in the healthcare system. And so at the Sagamore Institute, we're focusing on the importance of transparency, and price transparency being one of those. Now, price transparency will not fix every healthcare, but you cannot fix healthcare without price transparency. So this is all about holding the healthcare providers really accountable to things that are already in place, to being transparent on pricing. So if you have people that are already leery of the healthcare system and they're going in, if they have the access to healthcare, then they're going in blindly, not knowing even what this appointment or this particular service is going to cost me. So that is our focus of really just educating and really advocating. And in certain situations, you need to have legislation to really kind of push those providers to step up to the plate and provide transparency.
I agree. Mark, thank you so much for bringing up, I think, cost specifically, but price transparency as well. Medical bills are one of the largest areas of debt for Americans, essentially. And so I think that is a critical piece, a critical economic piece that plays a role here. I'm going to just ask a question. I'd love to hear from everyone. What issues do you think are at the root? If you had to pick the top 1 to 3 issues really that are at the root and creating these disparities, what would you say those are? KP, I'll start with you.
Well, if we don't all agree on what health equity is, then we have a problem, right? So in our country today, there is not consensus on what health equity is. And to be frank, if, you know, we're in a society now in our country where even talking about the topic of racism or accepting that racism exists in our society is a conversation. Like, we're debating that. Like, if there's a debate about that and we're not aligned on it, on kind of talking about that and understanding what's going on in our society, how can we talk effectively about what racial disparities in health are and what the drivers of them are, right? So I think that at the root of this, there's a much deeper set of issues that are going on around definitions. So for example, here in the state of Colorado, I'm a co-chair of the Health Information Exchange Working Group. And that working group is looking right now at the issue of standardizing how we think about race, ethnicity, language, gender, sexual orientation from a data perspective. So we can all align around what we're measuring and how we're thinking about what disparities exist. So that's like your baseline. But then as for the why questions, so even if we cross that bridge and we're able to measure, and then now we have to ask ourselves why these disparities exist. If we don't start to get into these root causes and deeper societal issues and align, it becomes very hard to design impactful interventions, right? So I think, you know, I just want to be forthright and say that that's what I see as are the root issues right now. Because what you find is, in many ways, if we just implement, and I'd be curious to hear from Dr. Nevins and others, but in many ways, if we just implement the best practice in clinical medicine, and there is not implicit bias or systemic racism, people's health outcomes are good, right? So then it's like the science is there to say if we implement these things well, people can be healthy, right? So then you have to ask yourself, why aren't these best practice standards getting implemented in a standardized way for everybody, right? And to me, that's the heart of the matter.
So what I hear you saying, I'm just going to paraphrase, is that racism and discrimination play a role. And, you know, I definitely think, you know, implicit bias is an issue. I worked for a long time for an integrated healthcare delivery system, and we educated a lot of providers on even what is implicit bias and, you know, how do we identify it and what does it mean in healthcare delivery? So I agree with you. I think it is, one, we need to be in agreement that it's an issue, and two, we need to then uncover where those biases are, and I think we know quite a few of them. And then be able to you know, go after them and understand them, and again, implement, you know, what I would call evidence-based medicine across the board. The other point that you made, I think, was really great around race data, essentially, even collection of data. So at same said integrated healthcare system, large integrated healthcare system, that was one of the biggest things that we were working on, is even having that data in the electronic health record across the board. So this idea that, you know, we're even asking those questions because we should be, you know, is an issue. And then making sure that that data is entered and we're able to access it in a meaningful way, I think is also very important. And when I look at, again, a system that was focusing on it and still how poor the numbers were, we have a long way to go. I'm with you. Juliette, I'd love to hear from you on, you know, what do you think the issues are that are most responsible for creating the disparities in healthcare equity and access?
Well, I'm going to delineate three. A, it's an ism. Racism, right? Sexism. I mean, if I go into the emergency room with chest pain, I'm going to wait an hour longer than the man for someone to take me seriously, right? And then because I'm Black and a woman, then I'm really in trouble. So we need to really be honest that it is a problem. Secondly, and KP, I have to sort of, you know, snatch up one of your statements in that I'm a very proponent of electronic medical records or systems that facilitate care that is agnostic, right, to race, gender, sexual orientation, blah, 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 blah. Right? And that way you eliminate individual bias if you have to do X before you can move on to Y. The third thing is cost. it's, when we think of cost, and Mark, in addition to transparency, I believe there's a notion that I don't think people understand that it costs the national economy when there are disparities, right? It's expensive. And from the payer side of it, I can tell you, I can see how much money goes when things go awry and you have the person coming in with uncontrolled diabetes, right? That only, trickles down. I mean, somebody is going to pay for that. And it's us, meaning that all Americans, irrespective of your line of business. So I think people need to understand that it's not those people over there. It affects the pockets, if you will, of everyone who lives here. So those are my 3 points.
I love it. Daryl, I'm going to call on you next. I'd love to hear from you. Same question.
Absolutely. And I think it comes down to 2 things, which is one is a lack of accountability and lack of perspective. We're talking about health disparities here. As far as lack of accountability, when you have these type of things, you have a health disparity, those begin to snowball. And once those snowball, because they're not being addressed, then you have the situations that we're in now. For instance, right now, Dr. Nevins brought up with being a woman and being in a hospital. You talk about patients who are in postpartum. You have a hospital who's constantly having issues, who are mistreating patients who are going through postpartum depression, and this is not being addressed. It begins to snowball and happens over and over and over again. And if the hospital does not understand that this is an issue, it's never going to be addressed. And that's a lack of accountability, and these disparities continue on. And as far as disparities, this is something that continuously, as far as perspective, this is something that continuously happens as well. You have people in these positions within healthcare who don't have a clear understanding of what the patient is going through on a day-to-day basis, and their ability to gain access to certain care. That's a huge issue. You have a physician who's just saying, hey, just go to your PCP. There's a lot of different factors that go into that. There's transportation. And then you have someone who has a chronic disease, they're having food insecurity. All of this builds on. It starts off, then now they need dental care. After dental care, now they start to get continuing issues. And now, as you know it, they're stuck in this cycle, and it starts to go down their family tree as well, as far as how they're viewing medicine, how they're treating medicine, and how their perspective of the illness within the family, going from lineage to lineage, as far as how they can address these things. And it starts to almost brainwash the patient almost outside of that healthcare system, as far as how they can treat these issues. And you see it all the time with mental health. Mental health is almost non-existent in the Black community, because that's something that we never had the initial access to and understanding of how to treat, because these health disparities have been persistent in our communities.
Great points. A couple of things. And again, just a tidbit of potentially where, and Juliette, I appreciate you talked about as well, like, where does innovation have a place here? I actually had the opportunity at an event here in Denver to put on some virtual reality goggles, and I had a hearing problem, and with these goggles I had macular degeneration, which essentially you lose sight from the center out, right, as you age. And I went through, as a patient, a visit with my healthcare provider in that situation, both this loss of hearing and loss of sight. And wow, like the empathy that I felt, and it gave a new perspective for me, just understanding that condition so much more. So I love your point, Daryl, about how do we get healthcare providers to understand some of those things, and maybe technology can play a role there. Mark, how about you talk about, so outside of cost transparency, talk a little bit more about what other issues you think are most responsible for these disparities.
Well, I think, sadly, we have a multi-tier system in terms of quality of care. So if you are in a Medicaid scenario, you do not have access to the same type of care as you would maybe a larger network. Mm-hmm. And people may think, how dare you say such a thing? But it is a reality. If people are on Medicaid, know that they have to go to the ER and that's how they're going to receive their treatment, well, then that just bogs down the ER. And if people aren't being seen because if there's some incentive to treat one patient over another, I don't know. But it's unfortunate that the healthcare system, I know it keeps coming back to that, but the cost of the healthcare system, again, as Dr. Nevins mentioned earlier, is it has this ripple effect. It affects the entire country. Maybe not one neighborhood versus another, but nationwide, if we don't have affordable healthcare, it's really a travesty. Everyone needs to be able to have access to it, and it comes down to a trust issue and transparency. Then we have a long way to go to build those bridges, I think.
Yes, and I agree completely. Sounds like I have a little bit of an echo right now, so I apologize for that. This is not a new issue, right? The idea that there are disparities in healthcare, but one of the things I'm hopeful for, COVID, a global pandemic, COVID has brought a few things to the forefront, and I am hopeful that. Unfortunately, disparities in healthcare happen to be one of them. We've all seen the data. We've all probably heard the news. But same thing with mental health, right? COVID has brought several things to the forefront, which hopefully we can spend a little more time putting focus on, because there has not been focus on them in the past. And Mike, it sounds like you're going to probably take us home here. And
I want to propose a framework for trying to pull together some of these threads. I mean, obviously, we weren't going to solve all of the world's problems in 30 minutes here, folks. We knew that from the outset, but there's some amazing points that have been made here. Like the first things that I wrote down were about trust, education, and technology as being solutions. But then we got into this idea of education, access, removing bias. All of these things start pulling together. Can we start and think about commonality issues? One of the problems we have when we say education, that's as nebulous as equity in the first place. Like, what kind of education? Are you talking about literally Sesame Street here? Or are we talking about much higher quality? Talking about interactive education? Talking about just teaching our providers to provide education at the point of care and accelerating that outcome. I'd like you guys to kind of like bandy about here a little bit more along the lines of give me focused potential solutions. And I know that's a little bit hard because it's such a large topic, but given the wide range that we covered, maybe our panelists' ideas on this and make my job a little easier for me.
So where to start with solutions? Mark, you can go first.
Well, you're right. Education is, a very broad sense, but I don't think it can be minimized, though. The importance of people knowing where to go or what is needed is critical. And so, I actually used to live in Denver, and I was with a healthcare startup company that focused just on that, was educating people to get better access to the healthcare. It was all through phone technology, and they had unlimited resources through all this education. So it's going to have to require baby steps. And I think for those people who have employers that are willing to invest in some of these companies that are trying to disrupt the healthcare system, they need to spend that extra dollar to say, hey, how can I get my employees better educated, and which will lead to better access. They'll know where they need to go and when they need to get the access for care.
Great. KP, where should we start with solutions?
Yeah, so I'm still kind of in the mindset of first aligning on measurement. What are we measuring? So, and again, it's a definitions issue. So if we talk about the isms, like what disparities are we measuring? So health equity is not just about racial disparities in health. It's about a wide range of issues. So if we can agree on what we're measuring and we can effectively measure disparities, then the next step is tying reducing disparities to value. And, my friend always says, follow the money. So if we can tie reducing disparities to value, You can watch the market move towards actually solving those problems, because frankly, as has been said by my colleagues, a lot of the cost issue in our health system also is inside of these pockets of underserved, vulnerable BIPOC populations. Poor health outcomes, high costs, low quality of care. If we can align the incentives and the value to that, we can watch the market move. But that starts with aligning on what we're measuring.
Yeah, I love it. So are we measuring the right things? Can we agree on what we're going to measure? And then how do we align incentives to make sure that, again, we are reducing? We can incentivize providers, systems, hospitals to reduce those disparities. I love that idea. I'm just going to point out quickly, one of the physicians and our CAB members in the audience talked about the fact that there's very limited compensation for health education. So this idea that we're going to, again, we got to follow the dollars, to your point, KP. Like, if we're going to educate, we got to pay people to do it. Juliette, how about you? Where would you land on, where do we start with solutions?
Well, if we stay within the education space, right, we have to educate patients. And I always like to use concrete examples because I think it helps to bring home my points. Diabetes. I've had so many patients walk into the office and say, oh, everybody in my family has diabetes, right? And that tells me that there is a lack of understanding about the cause of the disease and the severe sequela. Darrell, you talked about processes that get passed down from generation to generation. This is a place where you can innovate, right? There are lots of things that you can do on a phone, on the screen, to sort of interrupt that way of thinking within a family structure. So there's an example there. In terms of the provider side, the idiosyncrasies that individuals approach an individual can approach another individual with in terms of racism, I just learned that I am privileged, right? We talk about white privilege all the time, but I learned that there's English speaking privilege, right? There is a privilege of someone who is educated versus someone who's not. And all of these privileges separate you and create barriers. And I think, again, tools that allow people to empathize, because it teaches understanding, right, of not only but it demonstrates similarities between you and another human being. So in terms of education, I think that's a great place to insert technology in terms of changing how people think on both sides, the patient and the provider.
Yeah, I agree with you completely. One of the things that we tried to do in a role that I had on our diversity, equity, and inclusion team really was this idea of educating providers, because what we know is having a greater understanding of what our patients are going through, where they're coming from culturally, where they're coming from, related to a lot of those factors that you mentioned, Juliette, we're going to be able to deliver better care. And I would say, on the whole, those are not things. I mean, you can agree or disagree with me, but those are not things they talk about a lot in medical school. So we got to start at the beginning, right? And then educate the masses of healthcare providers that are out there now as well. Darrell.
Okay, I just want to tag on something to your statements before you redirect. Another space is getting providers who are aligned with the language, ethnicity, race of the target group would be very helpful. It's difficult to teach about nutrition if you're talking to someone who speaks Creole and who's from Haiti, right? Even if you spoke French, it's that cultural divide is a challenge. So that's another layer in terms of what we can do around the space of education.
I agree completely. Thanks for adding that. Darrell, I'll let you wrap us up, because I know Mike's probably itching to move us on. But where would you start with solutions?
As far as solutioning, it's getting boots on the ground, getting the innovator in the situation, or bringing in a stakeholder who understands the situation firsthand. I'll never forget, I was hired to make modular beds for labor and delivery over in Ghana. I get over in the clinic, I walk into the maternity ward, and I'm seeing the patients, they're laying on the ground, but I see all the physicians with a vial of blood tipping it back and forth. And I asked, what are you doing? Why are you guys just tipping this blood? And they say, oh, we can't bring the patient to get a C-section unless we know about their blood coagulation levels. I'm like, what about the lab? The lab takes 48 hours.
Oh, wow.
So we have some of those situations that I wouldn't have known if I would have never taken that trip over to Ghana, having my feet on the ground and understanding the situation firsthand. That's going to be important. And that's how a lot of devices, softwares, and initiatives are off target, because they do not understand the situations from their own eyes and from their own situation.
I love that point. And it brings us back to AngelMD in my mind, right? It is bringing the innovators and the healthcare providers together really to develop the best outcomes for our patients. So Mike, I'll let you wrap us up, but thank you all for being here. I have loved this conversation, and I could really continue to talk to you all for another couple of hours. So we're going to have to get this together again.